Thank you so much, and welcome everyone. And I'm just going to just check. Diane and Tara and others, I see you on my screen. So if my audio or any of this connection is not working, I'm going to look for a hand signal from one of you. But it looks as though it's working fine at the moment. Great. So everyone, it is truly an honor and a privilege to have the chance to share some time with you. As you just heard from Dan, I am a neurologist. The world I live in circles around the human brain. And for various reasons, I've chosen to devote my career to trying to understand the challenges that people living with epilepsy face and to come up with approaches to make their lives better. So I have to warn you, epilepsy is my passion. So I'm going to sort of dive into it with you and try to make sure that we all have a basic understanding of the nature of the illnesses that people with epilepsy come to us with. I have a handout that I've shared, and I'll be using it a bit as we go through the various topics, but I very much encourage you to ask questions anywhere along the way, anything. And I'll do my best to try to answer the question in the moment, but if there's something that you ask that I don't know about, I will get back to you one way or the other. So I look forward to any kind of rich discussion that we could have about seizures and epilepsy. Okay, so with that, let's start. Oh, I should also say that the way that I've framed this conversation with you is very much based on the way I teach epilepsy to our medical students here at the University of California, San Francisco. So every year there's about 150 students who come through UCSF, and given that seizures and epilepsy are so common, it's a topic that we teach regularly. And so the framework that I'm going to be sharing with you is very similar to what I teach here at UCSF. Okay, so let's start. As Dan just said, epilepsy is quite common, and it's universal all across the globe. Doesn't matter which country or which area of the world you live in, epilepsy is common. It's been known throughout all of written history. And overall, roughly speaking, believe it or not, about 1 in 30 human beings will develop epilepsy sometime during their lifetime. That's right. Diane, I see you saying, whoa, I'm surprised. Most people don't know that, but those data are quite clear. About 1 in 30 people will encounter epilepsy in their lifetime. And even slightly more than that will have at least a seizure during their lifetime, especially children. So it's a very, very common. So first question, what exactly is a seizure? And when I pose this question to my medical students, most people, including my students at the beginning, don't really understand what is happening in the brain when a person is having a seizure. Most people know what a seizure looks like, and we'll talk about that in a few minutes. But what I'd like to try to get you to understand is in your mind's eye, in the image that you have of what the brain is doing in someone who's having a seizure, I'd like you to understand, have a picture of what is happening in the brain during a seizure. And in order to create that image, we need to go back to the very basics of what the brain is actually made of. And all of you have heard this in one way or another, but let's just review. The brain, like other organs throughout the body, is made up of different cell types. And the cells are designed to carry out a certain function. So for example, we all know our skin, which is an organ, is made up of cells, and their primary function is to protect the inside of the body. So they're designed to be like armor to protect the body. Another example would be the cells of the heart. And of course, The cells of the heart are by design made to contract in a regular way in order to have a pumping action. The liver is made up of cells that clean the blood. So what about the brain? The cells of the brain, the main cell type related to epilepsy, are called neurons, and neurons are designed by nature to communicate with one another. They are communicating cells, and they send messages to one another by using electrical signals. So the cell is designed to have a movement of ions that are charged, that are electrically charged, and the direction that they move inside and out of the cell creates electrical currents. And so if Tara or Wayne, if you want to just share that one image on the top part of the handout, so those of you who have access to this page, you see this picture, and the larger blobs in blue here are examples of neurons. And the blobs themselves are the cell bodies, and then they have all these little connections that go between them. And you can really think of those as electrical wires. They're obviously made out of tissue, but that's what they do. And so these neurons, each of them in their own, are designed to send off an electrical signal that goes off to other cells in the brain. And that is what the basis is of the function of our brain. Electrical signals being sent everywhere. It's an amazing, amazing organ. Look, I'm biased. I think it's the coolest organ in the universe. But the thing is, there are 10 to the 10th neurons in the brain. 10 to the 10th. A reminder, 10 to the 6th is a million. So there are 100 billion neurons in the brain. But what's even more amazing is that each cell makes a connection with another 10 to the 5th neurons, which is 100,000. So each neuron on average makes a connection with 100,000 other cells, and there are 10 to the 10th of them. So that the total number of connections in the network is gigantic, right? But of course, that's what allows us to be human, to behave, to do what we do. Okay, so this is what's in our brain right now. Now, if we could listen in to the electrical signaling of the brain in this moment, as we're all listening, talking, moving our body, if we could listen to the overall amount of activity, like little clicks, it would sound like just noise. It would just be this general noise going on, like background noise. Or imagine if we were in a stadium, a big soccer stadium, and it was filled, 100,000 people. We just hear this noise. That's what is going on in our brain in this moment. But of course, the noise makes sense because if it's the stadium, it's people talking to one another. So it's not as though it's just chaotic. It's actually creating, it's just representing the baseline activity of what's going on in the brain. Is everyone with me? Does this make sense? Okay, I'm seeing some nodding heads. That's good. All right.
Yes,
okay, so here's the key. During a seizure, a large group of neurons suddenly start behaving in an abnormal way, and they start sending off signals at a higher intensity and a very, very synchronized way. That is not normal for the brain. That is not normal. So when we're talking about person having a seizure inside their brain in a defined place, which we're going to get to in a moment, a large number of neurons, maybe all of them, are suddenly firing away in a hyper excited way in a very synchronized way. And that, my friends, is what a seizure is. Okay? So as we go forward, we're going to talk about what it looks like. But I now want you to imagine in your mind's eye, when you're looking at someone having a seizure on the ground, that that's what's happening. These neurons are firing away uncontrollably. Okay? All right. So in order to understand the different seizure types, we need to quickly take a look at the different parts of the brain itself. Because as you all know from your basic education in medicine, the brain has different parts to it. And here's an image that shows the basics of this. And I'm really just mostly going over something that you all know, but I want you to appreciate some of the important differences. So our brain, the human brain in this case, it has a front, it has a back, has a right side, it has a left side. For the most part, it's pretty symmetric in terms of its function. But the most important areas and all relevant to seizures and epilepsy are shown here. So one of the more basic places is in the back part. It's kind of like in the middle part of the brain. It's actually technically the back part of the frontal lobe. Just a reminder, there are 4 main lobes. There's the frontal lobe in front. There's the parietal lobe just behind it. There's the occipital lobe all the way in the back. And then there's the temporal lobe that sits to the side, right and the left, sort of within where our ears are inside the skull. In the back part of the frontal lobe is an area that is completely devoted to movement, and shown here in the slide. So those neurons, when they fire, are controlling the movement of our body. Just behind that, in the parietal lobe, is an area that has to do with sensation. So when we touch something, the signal is sent up to the brain, and we interpret it as a feeling of touch. And that could be either painful, or it could be light touch, or it could be cold or heat, but that's where that activity is taking place. In the very back of the brain, in the back of our skull, is where the occipital lobe is, and the occipital lobe is devoted to vision. So everything that you're taking in right now is coming into your eyes, goes through the optic nerve, and gets sent back to the occipital lobe and is processed to create the visual world that you're sensing right now. Along the side, the temporal lobes is an important region that contains a structure called the hippocampus. Have you guys heard about the hippocampus in your studies? I'm sure you have. The hippocampus is really important because it is the structure that allows us to create memories. So, for example, if you've been listening to what I've been talking about for the last 5 or 10 minutes, and tomorrow you actually can remember that I was talking with you for the last 5 or 10 minutes, the only reason you're able to do that is because your hippocampus is taking in that information right now, and it's creating the longer term memories. And this will become relevant in a few minutes when we talk about different seizure types. But just remember that the temporal lobe is where memory and also emotions are created. And then finally, in the front, I've left the best for last, if you will. The frontal lobe, way in front, is where our thinking is happening. It's kind of where our consciousness exists. And it is the part of the brain that makes us most human. If there's any part of the body that is the most distinctive and allows us to be human beings, in fact, it's this front part of the human brain. And it's pretty incredible to think that the neurons that make up the frontal lobe, this part of the brain that makes us human, could fit roughly into our cupped hands. Just that. All right. So now that you understand the cells that make up the brain, and you have a reminder of the different regions of the brain and what they do, we can now dive into what may be one of the most important teaching points I can share with you. And that is that there are different types of seizures. And the reason this is important clinically is that this is, in fact, I'm going to say it again to myself. This is incredibly important clinically, because most people don't appreciate that there are different seizure types, but we need to understand different seizure types because it has a lot to do with both the diagnosis and the treatment decisions that we make. Okay, so we're going to go into the classification of different seizures. As you'll see in the handout on the top of the second page, there are three major types of seizures. And let's just walk through the different types. The first we call focal. And the reason we call it focal is that the group of neurons that are firing uncontrollably are just in one part of the brain. Okay? So, given that, I'm going to actually ask you a question, and anyone can answer. You can put it in the chat. What would a seizure look like if we put the focus? Okay. In fact, let's do this. Let's do a mind experiment. Let's imagine that I have a seizure generator. Okay, a little device that I could hold over the person's head or my head, and when I turn it on in the region where the device is affecting, it's going to create uncontrolled firing and synchronization of a group of neurons. In other words, it's going to create a seizure just in that area. All right. So what if we placed the generator over the left part of my brain, left brain, in the back part of the frontal lobe? What would that cause? Anyone? And by the way, let me just say, when I'm with my UCSF medical students, I tell them, I don't care what your answer is. You could be wrong, you could be right. That doesn't matter. What I want is for you to think about this with me, and come up with any answer you can and imagine. And I should also say, I'm very patient. I could wait for hours for an answer. Anyone? A seizure in the left side of my brain, in the back part of the frontal lobe. What would that do? Anyone?
Let me jump in. Are you asking for what type of seizure it is, a focal, a generalized, or a focal that becomes a generalized, or what part of the brain and what the brain does it will affect?
Yeah, good. Thank you, Diane. No, what I'm trying to think is what clinically would happen. What would you observe in me if we induced a seizure in my left back part of my frontal lobe? What would happen to my behavior, do you think? Mm-hmm. What would be affected?
There would be, the movement will be affected.
Exactly. And just a extra question, which side of the body would be affected?
The opposite side of where the excitement has been exhibited, where your generation has come from.
That's exactly correct. So there's a little bit of neuroanatomy behind this, but the left side of the brain affects the right side of the body. And so you're exactly right. If we placed the seizure in the left part of the frontal lobe, which controls movement, I mentioned that right at the beginning when we talked about different parts of the brain, the seizure that's created would be abnormal movements on the opposite side of the body. Okay? And that would be called a focal motor seizure, a focal motor seizure. And those seizures exist. Now, an advanced question would be, do you think that consciousness would be affected? Would the person lose consciousness? And I'll tell you the answer. If it's just in the this focal area affecting the motor region of the brain, the person would not lose consciousness. Because in order to lose consciousness, you have to affect a much larger part of the brain, or the more sophisticated parts of the brain, like that temporal lobe and the front part of the frontal lobe. All right? And the reason I want to emphasize this is that, as we'll come to in a minute, there are many types of seizures, and they're not only those big generalized seizures that we've all seen where people fall to the ground and have lots of movements and they're unconscious. So focal seizures may not impair consciousness, but they're still a seizure. Okay? Now, we can continue the experiment. It's going to get a little bit easier, because if we move the seizure generator, which, by the way, there's not really a seizure generator out there. I'm just making this up. But if we move the generator back to the parietal lobe, which has to do with sensation, then the person's seizure would be that they feel something abnormal on the other side of the body. But they wouldn't necessarily have movement. They wouldn't have loss of consciousness. Okay, so we would call that a focal sensory seizure. And I imagine some of your more experienced clinicians have seen these different focal types. Okay, now it's going to get a little bit more complicated, because what happens if we put the seizure generator on the temporal lobe, Do you think there's going to be a change in behavior? Say yes.
Yes.
Good. Yeah. So what do you think could happen? A seizure that's affecting the temporal lobe. Memory loss. I see that Felix wrote down memory loss. Exactly. That's exactly right. And there might be some change in the person's sense of emotions. Okay. So this would create quite an abnormal behavior. Imagine what it's like if you suddenly lost your ability to create any memories. You would look confused. You would not know what's going on. So your awareness of the outside world would be affected. You would not behave normally. And we call that a focal complex seizure, because the behavior abnormality is complex. And again, this doesn't involve someone falling to the ground and suddenly having big convulsion movements. We're going to get to that in about half a minute. But again, I just want to emphasize that there are these different seizure types. And we need to appreciate that, because not understanding that contributes to the misunderstanding of the behavior of people with epilepsy and contributes to stigma. Okay, so those are all focal seizures. Now, the second category, as you saw from the list, is generalized. And a generalized seizure is basically abnormal excitability and hypersynchronization of all the neurons across the entire brain, essentially at the same time. A generalized seizure. Now, I mean, how does this occur? It's got to start somewhere. But it just quickly takes off over the entire brain. And the analogy that I have in my mind is there's a dry field, very, very dry field, and someone throws a match, and it instantly just takes over the entire field all at once, just very, very quickly. And that's what a generalized seizure is. So a nice way to think about the difference between a focal seizure and a generalized seizure is to go back to that soccer stadium that we were talking about before. Okay. Now remember, normally the soccer stadium, there's just all this background noise, which of course makes sense if you're talking to your friend, but overall it's just a bunch of noise. A focal seizure is like when one section of the stadium suddenly decides to scream out loud all at once. Okay, but it's just one section. A generalized seizure is when everybody in the stadium, say, sees an exciting goal and everyone screams at once. That's a generalized seizure. Does that make sense? Okay, and the key thing about a generalized seizure is the whole brain is having the abnormal activity. So the person may have movements, abnormal movements, because both sides of the motor component of the brain are firing away uncontrollably. So they have shaking movements. And they're typically, not just typically, they always lose consciousness. Because if the entire brain is not firing normally, then we will lose consciousness. Okay, and that brings us to the third category, the third one, which is a focal seizure that then grows and becomes generalized. Okay, I really, really want you to understand this, my friends, because most people don't. Most people think when a person has a seizure, they've had a generalized seizure. But you are taking care of a significant number of people who have a focal seizure, but they then present with a generalized convulsion. And what's happening is they have a region of their brain that is susceptible to focal seizures, and sometimes they may only have the seizure in that area, and that's the end of it. But at other times, that focal seizure begins to spread and spread more and spread more, and then it takes over the entire brain and they have a generalized convulsion. The best way to picture this is go back to the soccer stadium. In this case, an area, a section has started having the seizure activity. They've started yelling and they're very excited. And then the sections next to it start spreading as well. And everyone else gets involved until the entire stadium is applauding and cheering and making noise. That's a focal seizure that's secondarily generalized. Okay, so before I move on to the next part of this, let me stop for a moment and ask if there's anyone who has any questions, because at this point, if I've been successful in teaching you this material, every single one of you should have an idea, a general idea of when you see someone having a seizure, you're picturing those neurons firing uncontrollably. And when I ask you, what are the different seizure types, you have an appreciation that there are focal seizures, and the behavior that occurs depends on where the seizure occurs. There are generalized seizures, and then there are people who have focal seizures, but sometimes they generalize. So let me stop there and ask, any questions related to this first part?
Dan, I have a question.
Yes.
I'm curious, does a person remember anything? Like, let's say they have a focal that goes general. Can they describe afterwards? Like, oh, at first I couldn't see anything, and then all of a sudden I couldn't experience, can they give you any feedback about it? What kind of feedback would you hear from a patient afterwards?
Yeah. So that is a great question and very clinically relevant. And we're gonna dive into that a little bit further in a few minutes when we talk about how to make the diagnosis. But just to say, it depends on the seizure type. And for someone who, say, has just a sort of a simple motor seizure, since they don't lose consciousness, they could actually be talking to you during the event. In fact, oh, here, Diane, here comes, I'm having one of my motor seizures. My hand is twitching. And this is what happens when I have this darn seizure. It should go away in a minute or so. but I'm aware of it happening because the rest of my consciousness is preserved. On the other hand, if the focus is in the temporal lobe and memory is impaired, they may be able to describe as it starts. And again, we'll get into this in a few minutes, but they won't have any recollection of what happened during the event. And the same is definitely true with a generalized seizure. People will not be able to tell you what it was that they experienced during the seizure, although they may give us very important clues about the onset of the seizure. Good. Milo, who's here, just sent me a note and asked me to mention there's a certain seizure type that that's called petit mal, or absence epilepsy. And I don't know how common that is for you to encounter or to diagnose, but it is an important form of a generalized seizure that we can talk about more, but it also involves the entire brain all at the same time. But what's very different about it is it's not so uncontrolled that it causes the person to drop to the ground and have convulsions. It affects pathways that essentially make the person lose consciousness for just a second or two, or a few seconds, and then they come right back. So they don't collapse to the ground. They just appear like they're daydreaming for a few moments. It typically occurs in younger children, not associated with any kind of injury or anything else. Usually school age, ages 4, 5 to 10 or 11. And these are children that we see who just have these momentary lapses of consciousness that it turns out is due to a generalized seizure. The only way to make the diagnosis really is by clinical observation, but especially if with an EEG, because the EEG shows a very characteristic electrical signal. Okay. All right. Should we move on to are there any other questions related to what we've just covered? Again, if anyone's not following this, please, I beg you, ask your questions about it, because it's really important for all of us to have the understanding of these fundamental concepts in order to make sense of the patients that we take care of. We're good?
I have a question.
Please.
I'm epileptic. And when I convulse, I feel it coming.
Yes.
And I convulse for seconds. And then I feel it coming and I lie on the ground or I sleep. Then it comes for seconds and goes. What kind of epilepsy is that? And I'm on Lamictal.
You're on Lamictal. Okay.
Yes.
Yeah. So if you feel it coming on, almost by definition, it's starting focally somewhere, but then it's generalizing. When you have your full seizure, are you unconscious for a short period of time?
Yes, I am.
Yes. So you're having a focal seizure that then is generalizing, and we're gonna talk about your symptoms actually in a few minutes. This is going to be very helpful. Who was speaking? What's your name?
My name is Eunice.
Eunice.
Rogoro.
Okay. If you don't mind, if you don't mind, it'd be very helpful when we're going to talk about what the symptoms are that people describe, and I really appreciate your willingness to share this with us.
Okay, thank you.
Good. Yeah, you're welcome. Okay, so now let's turn to
Dan, we actually had a couple more questions came up.
Okay, please. Yeah.
So Shem said, can a seizure result to convulsions?
Yes.
And then there's one more after you finish that one.
Okay, I see that. Is it a type of shock circuit between two nerves? Okay, yes. Okay, so in terms of can a seizure result in convulsions? Yes, because the definition of convulsions is abnormal movements of the body. That's what the word means. So if someone's having these shaking movements, which we see when someone's having a seizure, those are convulsions, and they are due to the fact that the parts of the brain that have to do with motor movement are abnormally excited and synchronized. Now, but a seizure, we've already talked about the fact that a seizure doesn't necessarily have to cause convulsions because it depends on where the seizure is coming from. If it's coming from the sensory region of the brain, there's no movements involved. It involves abnormal sensations. And then the other question is does it occur? Is it a type of shock circuit between two nerves? Yeah, that's a reasonable way to think about it. It's like abnormal excitability between a group of neurons. But I should say it's not just two neurons. It's got to be a lot of them. Like, remember, I said that there are 10 to the 10th neurons in the brain. So we're talking about a region that might involve many thousands of neurons at one time to create a seizure. Okay, and then we've got some questions. Jeffrey and is it Chacha? Yes, are asking really good questions, which lead me to the next topic. So you've set me up perfectly. All right, so let's talk about epilepsy and its causes. Now, so far, I've really mostly concentrated on seizures. I haven't really talked about epilepsy per se, because there's a big difference between the definition of seizure and epilepsy. A seizure is the single event that we've been talking about. It's that event of uncontrolled firing of neurons. But epilepsy by definition in the textbooks is, quote, a tendency for recurrent seizures. A tendency for recurrent seizures. In other words, if a person has a single seizure, they do not necessarily have epilepsy. Very important distinction. Very important. Because we see lots of patients who have had just one or even only 2 or 3 seizures, and they will never have another seizure in their lifetime. And you've all seen this, the children who come in with fever and they have a seizure and they otherwise are fine. Those children, the diagnosis is febrile seizure, but they do not have epilepsy. And this is important for our patients and their families, right? Because if they don't have epilepsy, but we discharge them from the clinic with the diagnosis of epilepsy, they're going to carry that stigma with them going forward. And they're carrying the incorrect diagnosis. Okay, so epilepsy is a condition in which a person has a tendency for repeated seizures. And if that's the case, they have an underlying condition that makes them susceptible to recurrent seizures. And as you can see in the handout, there's a brief list of some of the different causes. And you are familiar with all of them, I am sure, for any of you who have clinical experience. Certainly, one of the most common forms of epilepsy is brain injury. And I know in your country, similar to all across the world, that motor vehicle accidents and other causes of injury, traumatic brain injury, create a wound in the brain, and that wound is what the cause is of the person having seizures. And as you can probably imagine, the type of seizures that people who have brain injury have are focal and focal with secondary generalization. Stroke and other lesions that disrupt or injure the brain can also cause epilepsy. Tumors, as you can imagine, disrupt the organization of the brain in a certain region and can create epilepsy. A very important area, and one that I happen to spend a lot of my time studying, is our recognition that our genetic makeup can predispose us to epilepsy. And in fact, a significant portion of people with epilepsy have a genetic basis. In other words, they don't have a brain injury. They haven't had traumatic brain injury. They haven't had an infection. They haven't had a stroke, and yet they do have recurrent seizures. In those cases, we're concerned about the possibility that there might be a genetic basis. You all see a significant number of people who have seizures and recurrent seizures because of infection. In the case, for example, malaria. But malaria that causes epilepsy is not just because the person's having a febrile illness. It's because the malaria organism has caused changes inside the brain structure itself and is predisposing the person to having epilepsy. And then probably the most common cause of a person having a generalized seizure when they come into our clinic is because they have a metabolic abnormality. In other words, there's a problem with their glucose. They have diabetes, or they have some other inflammatory process, some other generalized infection, or very common here in the US, I'm sure it's true there as well, where there's a lot of alcohol abuse. Alcohol can cause a metabolic change and therefore cause a generalized seizure. Okay, so let's see, I think, relative to these questions, what is the typical cause? Okay, yeah, these are good questions. Are seizures or epilepsies inherited or acquired conditions? The answer to that question is it can be either. So a person can otherwise have a normal brain and then have a brain injury, like being in a motor vehicle accident. We call that an acquired form of epilepsy because they have an acquired new injury that injured the brain and they now have epilepsy. On the other hand, it can also be inherited. So the person may have had a brain that was predisposed to epilepsy from when they first developed as a fetus, and it eventually emerged as their brain developed. Another question is, can epilepsy be treated or is it a lifetime condition? Depends on the cause of the epilepsy. So if a person has a genetic cause, in some cases they may grow out of it because of the way the brain develops. In other cases, it may actually be permanent. Similarly, if a person has a brain injury, like a motor vehicle accident, they may develop epilepsy for a certain period of time, but as the brain heals, the epilepsy goes away. But that is certainly not always the case. Here's a question that my students ask all the time too. This is from Alex. This is a really, really important question. Can epilepsy lead to permanent brain damage? So it turns out that people who have many, many, many seizures, and I'm talking many, many uncontrolled seizures, that actually can lead to some loss of additional neurons. But it really depends on the individual person. In some cases, it doesn't cause any notable change over the course of their lifetime. But in other more severe cases, and I'm sure many of you have seen this, you can see that a person has developed epilepsy and the impact of the epilepsy gets worse over years. And then finally, are there predisposing factors to seizures? We're going to come back to that in a few minutes. Okay? All right, so you should now appreciate not only what's happening in the brain of a person having a seizure and the different types of seizures, but you're very clear on the difference between the word seizure and the word epilepsy. They're two different things, right? A seizure is the event itself. Epilepsy is the condition where there's this tendency to have recurrent seizures. And we want to really be careful when we make these diagnoses in the clinic. Okay, next topic. And I think we're doing okay for time. Good for you? Okay. So let's just quickly go over, what you should do when you see a person having a seizure. And this is in your handout. And the basic idea is when a person is having a seizure, whether it's in clinic or during a home visit, or you're taking a bus and someone suddenly collapses and they're having a seizure, the most important thing is to try to keep them from hurting themselves, from moving around or knocking into something. People who have seizures almost always don't have a problem with breathing, even though it looks like they might. So as a general rule, you just want to make sure that you take care of, their airway and their breathing. but that's usually not a big problem. What's more important is to get them into a safe position, presumably on the ground, on their side, so that if there's any kind of fluids or whatever coming out of their mouth, that they don't aspirate. So just simply turn them to the side and let the seizure run its course. Most seizures almost always end within about a minute. Within about a minute. The other thing that's very important, and I'd be interested to know what you do, but unless you're in a very controlled situation like in the clinic, you should not put anything in the person's mouth to try to keep their jaw open. Some people think that a person's going to swallow their tongue. That can't happen. It's not physically possible to swallow your tongue. So you don't have to worry about that. But the other thing that people do is they want to put something in the person's mouth to keep them from biting their tongue. Because during a convulsion, a person may contract their jaw and their tongue gets stuck between their teeth and they can get a very, very bad wound. The problem is, if they're going to bite their tongue, it has already happened. So once a seizure occurs, you are not going to be able to be helpful by putting something in the mouth to keep that, unless you have the right type of device in the clinic. So people should not be putting spoons and sticks and other things in the person's mouth. There's a good chance you're going to injure the oropharynx, the mouth, by doing that maneuver anyway. Okay? So that's the simple approach to first aid. Now, let me now turn to another critical topic, and that is how to make sure that your diagnosis of someone having had a seizure is correct. Because it turns out, I can tell you here in California, in the United States, in the emergency room, one of the most common issues that we face is someone is brought in by their family or a friend, and they've lost consciousness. And the person who brings them in says, "Oh, I definitely saw her having a seizure." Well, it turns out that having a seizure is not the only way of losing consciousness. In fact, there's something that is a lot more common, and that's called fainting or syncope. And people faint all over the world. In fact, I'll bet you that among the, what do we have? We have like 50 people here. I'll bet you that at least a third, if not a half of you, including me, have fainted. Okay? And for those of us who have fainted, we've all had a pretty similar experience, as it turns out. The cause of the faint may be different. So for example, I'm going to tell you a little secret about me. When I was, let's see, I must have been 7 or 8 years old, and I was in like 3rd grade. And for reasons I don't understand completely today, the boys in the class thought it was very cool to make themselves faint. And to do that, what we would do is we would hyperventilate. And when you hyperventilate, you change the blood flow into your brain. And then what we would do is we would squeeze our body really hard. And what that does is it actually prevents blood from getting back to your heart. And the combination of hyperventilating and squeezing your chest like that, and I'm not recommending that any of you do this at the moment, but to do that, you actually decrease the blood flow to your brain. And a faint is caused by not having enough blood going to your brain. And so when I can still remember doing this in 3rd grade, and I would just collapse. And what I remember is what you all who have fainted will also remember. And that is, as you're starting to faint, your brain becomes kind of woozy. You start feeling like things are kind of beginning to go out of, you're just losing consciousness, and your vision starts to darken. And then you just sort of lose consciousness and collapse. But what's so important about a faint is that we can generally describe what the initial symptoms were. And so when a person comes in and is described as having losing consciousness, it's really important to take a careful history and find out what is it that they were experiencing. And they may say something like, well, you know, I was working on something and I cut myself, or I saw someone getting cut and it made me feel really, really uncomfortable. And I started feeling like I was getting lightheaded. I was seeing stars. My vision started darkening, tunneling down. And the next thing I know, someone was trying to wake me up. The description of those symptoms just leading into a loss of consciousness is much more common for syncope or a faint than it is for a seizure. Okay? Another reason to faint is if you haven't had enough fluids, or you have an infection and you suddenly stand up too quickly. And the faint is due to the fact that because you're hypovolemic, you don't have enough blood circulating, your brain doesn't have enough circulation, and you collapse for that reason. This is to be distinguished from a seizure. In a seizure, a person may not have any warning at all, or they may have some symptoms, but they're very, very typical for that individual. And the reason that they're having those initial symptoms is because the seizure has actually started focally and is creating the symptoms, and then they then go on to lose consciousness. Okay, so if we can go back, who was it who said that they have a warning? Can you?
Me.
Yeah. Can you describe that again?
Okay. When I'm conversing, sorry, I'm in a dark place.
Yeah, go ahead.
I feel it coming. I see strange, and then I sit down, yes, and converse.
What is it that you feel? What exactly do you feel when it's coming on?
I see strange things. I don't know. I see strange things, and I feel afraid.
Yes. So that would, so the word that we use for that, for what you're experiencing, we call it an aura, A-U-R-A, right?
A-U-R-A.
Yeah, A-U-R-A. And yeah, that word actually comes from the Greek language, and the Greek used the word aura. It means breeze, a light wind, And an aura, the Greeks use that because it's like the breeze is making, you can feel that something's happening in the weather.
Yeah.
Yeah. And for you, what's happening is in some part of your brain, there is a small seizure that's beginning to create a little bit of a breeze.
Okay.
And I imagine that there may be times when you just get the aura, but you don't convulse. Is that possible?
Yes, especially when the convulsions are convulsed a lot. Then these are the last times of convulsions. I feel it and I don't convulse.
So there you go. You've just heard about someone who is having both a focal seizure that then generalizes, causing the convulsions, but also can have just the focal seizure. And this is such an important example that I want you to appreciate, because this is telling us that the cause of her epilepsy is originating from some part of the brain. And that can have an impact on the choices of drugs that we use for epilepsy, because some of them are better for focal seizures and some are better for generalized seizures. And we'll get to that in a few minutes.
Okay.
Yeah, thank you. Thank you. So let's see, I'm seeing a whole bunch of, these are, boy, you folks are good. do people get confused on the difference between fainting because of lack of food, et cetera, and seizures? What is important about this? Let's see. Do people get confused on the difference? Oh, yeah, that can be confusing. Like if someone comes in and they say, I think I fainted because I didn't have enough breakfast. That's not a very good way of distinguishing between a faint and a seizure, because the person could say the same thing about having a seizure, if that's what you mean. In fact, this just reminds me, let's just take a look at this this chart, which is on this bottom half of the page 3. And I would say of the things that are on the handout, I really, really want you to know this one. In fact, I tell my medical students this. In fact, I tell my medical students, look, there's going to be an exam at the end of my course. I'm going to ask you about this chart. So they really learn it well. But let's go through this. So I've already tried to emphasize that if someone comes in and they've lost consciousness and it's not clear yet whether or not they've just fainted or they've had a seizure, getting a careful history about the onset is really important. So you need to take a few minutes and walk them through. Tell me exactly what you experienced. And if they start describing something like, well, I was feeling kind of woozy and I started seeing stars and I felt lightheaded, I felt my heart maybe beating really quick, and then I kind of just lost, I just collapsed. That is similar to what all of us probably imagine when we fainted. And that would put us in the direction of a person having a syncope. On the other hand, if the person's seeing odd things like we just heard, or their mind is kind of racing, or they feel emotional, that pushes us more in the direction of this being a generalized seizure, or one that's focal, secondary generalized. Okay, the next row is also really important. Most people don't know this, but during a faint, during a syncopal episode, it is actually quite common for a person to have abnormal movements. Most people imagine that when a person faints, they just lie there without any motion. It turns out that up to half the time, a person may have some movements. However, they never last more than 10 seconds. So that means that if someone comes in and their friend says, well, oh yeah, they were shaking. If they were just shaking for 3 or 4 seconds, that could be consistent with having fainted. But if their shaking has gone on for more than 10 or 15 seconds, that is not consistent with syncope, and we would call it likely a generalized seizure. Okay, so that's point number 2. The third, the row says skin color. This obviously depends on one's skin color and how dark or light a person is. But during a seizure, because of the increased blood pressure that occurs, a person may appear cyanotic, and you can see that in the eyelids, for example, just, regardless of what their underlying skin tone is, or in their lips. But that's not necessarily helpful. But the last one is extremely helpful. And that is how long it takes for a person to recover. If a person has a typical faint, they may be unconscious for about a minute or so, but they always are waking up within a few minutes. So if you fainted and you collapsed to the ground, within 2 or 3 minutes, you may not feel normal at all, but at least you're able to hear and have a conversation with someone. You may feel groggy and sleepy, but you can at least understand what's going on around you. In someone who has had a full convulsion, a typical generalized seizure, say from diabetes or alcohol abuse, or a focal with secondary generalization, they are never normal within a, I should never say never. In medicine, you never say never. They almost always will take many minutes to get back to the point where they can interact with other people again. And that's usually 10 or 15 minutes. Okay? So these are the ways we make a distinction between someone who's had a faint and someone who's had a generalized seizure. And it's it's very important diagnostically because a person who has fainted may have a problem with their blood volume. They may have a problem with a generalized infection. They may have a problem with a cardiac rhythm, and they need to have an EKG and be evaluated for a heart problem. But this is very different than someone who's had a seizure where we're concerned about something going on in the brain. Does that make sense? Okay, good. Let me just check our questions here. How does a photosensitive? Okay, so there's a question about what's called photosensitive epilepsy, and that is that's a particular type of epilepsy where the seizure is caused by rapid strobe-like effects of light. And yes, this occurs. The reason we think it occurs, it causes the brain to start getting synchronized in a way. And can video games be a trigger? Yes, theoretically, but very, very rare. And then there's a question about what's the difference between a migraine aura and a seizure. That's a beautiful question. Thank you for asking that, because we use the word aura for migraine as well. And basically, I'll just say they are different. I mean, a migraine is a very different electrical phenomena in the brain. It has different characteristics. It does occur in part of the brain, and it can spread slowly. And it's that abnormal electrical spread that causes the aura of migraine, but it's quite a different phenomenon. And then, boy, incredible questions. Someone's just asked, Rigoro's just asked, what are non-epileptic seizures? So non-epileptic seizures are behavioral events that are not due to the abnormal hyperexcitability and synchronization of parts of the brain, but they are due to abnormal function of the mind. In other words, there are people, and it's a significant number of people, who, because of mental illness, because of, say, depression or trauma, the consequences of early physical or sexual abuse as a child, that their mental health is such that one aspect of their abnormal behavior is that they actually have seizure-like events, and we call those non-epileptic seizures. They are just as important, needless to say, as having epileptic seizures, but their cause is very, very different. And here's another important observation that, again, most people don't know, and that is that here in the United States, about half the people who have non-epileptic seizures also have epilepsy. So it can be very, very, very challenging to be able to treat both the epilepsy itself as well as the mental health condition. And both cases need to be taken very, very seriously. Okay, so again, I'm just looking at time, and now, Diane, we were worried we wouldn't fill up the hour and a half. No problem. And I want to be respectful of everyone's time. Let me just turn to treatment and assessment, and I can see we're going to have plenty of other questions to discuss. So in terms of the approach to, let's assume that we've made the diagnosis of epilepsy in the emergency room. So now it's not syncope. We've decided it's a seizure. This person has had a few seizures. We therefore think that they have the tendency for recurrent seizures. What are we going to do? Certainly, for anyone who comes in with having a seizure, we want to make sure we understand what their medical condition is. So I'm sure you do in the clinic a certain number of available laboratory tests, such as a blood glucose, or you might get a CBC to see if there's an infection. You might send off for a malaria test. I know you have limited access to imaging, but in some cases, you may or may not choose to get an X-ray. If things are complicated, you may send them off for an imaging study where there's an imager that's available. But basically, we want to try to understand what any underlying medical issues are. If they come in and it's clear that they've been abusing alcohol, then the primary approach to treating them is to help them deal with their alcohol addiction. So we do that first. Someone asked before, are there things that predispose a person with epilepsy to have seizures? Yes, for sure. And the number one predisposition is sleep deprivation. Sleep deprivation causes the brain, causes any of our brains to become abnormally hyperexcitable. All of you have experienced this. If you've stayed up or not been able to sleep, your brain feels kind of buzzed. You feel terrible. Well, your brain is just kind of getting buzzed. And if you have an underlying predisposition to having a seizure, you've just made it even more likely. So one of the best things that we can do to our patients who come in, who we've made the diagnosis with epilepsy, is to counsel them on the importance of very careful sleep hygiene, of doing the best they can to sleep well, and to avoid alcohol and other drugs if they can. And if they have diabetes, to treat their diabetes as carefully as they can, and to otherwise take care of their body, treat themselves holistically. And then we may make the decision to treat them with a certain anti-seizure drug. In the acute setting where someone's having a seizure, we may give them a benzodiazepine. And I know you have diazepam to be used. And that's a very effective drug for stopping a seizure while it's occurring. But it is not a very good drug to be taking on a regular basis because it just has side effects, especially sleepiness, and it'll cause impairments in memory. Diazepam can be useful if the person knows that they're having a seizure coming on and they can quickly take the pill. And I don't know, can I ask, do you have patients who are given diazepam to be used just when they feel like they have a seizure coming on? We call that a rescue med. Do you use that out there?
No, we don't.
Okay. Yeah. That's something that we should talk about, maybe as we think about approach to caring for your patients going forward, if we could come up with some way of enabling, again, what we call rescue therapy. But then the other drugs that you use, phenytoin, phenobarbital, carbamazepine, and valproate, I'm sure you have your own approach to which drug should be used, but coming back to the importance of making the diagnosis of focal versus generalized epilepsy, overall, if you're going to choose a drug for a focal epilepsy, a drug like carbamazepine is better than a drug like valproate. So that would be a good example of where you would want to understand the type of seizure in order to make a therapeutic decision. So again, in general, a drug like carbamazepine, or we heard another drug that sometimes is available, Lamictal, those drugs are better for focal or focal with secondary generalization, right? So the person who has an aura, but also has convulsions, I would choose carbamazepine or Lamictal or phenytoin rather than valproate. Unfortunately, we can't predict very well which drug works best for a given person, but this is some general guidelines as to what you would choose. Okay, so now we've had the person, we've made this diagnosis, we've decided which treatment they should go on. As we talked about at the beginning of the hour, we don't know what the future for this person holds, unfortunately. We don't know whether the seizures may go away in a year or two, or it might be a lifelong condition. So we need to prepare them for the challenge of living a life with epilepsy. And so let me then turn finally to the things that we need to keep track of in the patients that we take care of, whether it's during a home visit, or they come into the clinic for a regular checkup, or they've come into the emergency room because they've had a recurrent seizure. And the key thing here is for us to let me just start with helping them cope with epilepsy, helping their family and their community live with epilepsy by trying to do everything we can to help the patient and the people around them to understand what the nature is of their condition. So I've just spent more than an hour trying to help all of us come to a common understanding of what the biology is of having a seizure or epilepsy. And I think you can all appreciate that the best weapon, if you will, against stigma is understanding. The more we can understand why something has occurred to a person, the less likely stigma exists. And here's a really good example. If someone comes in from a motor vehicle accident and they've fractured their femur, is there stigma around fracturing a femur? Not at all. And why is that? Because everyone who looks at that person understands that they broke a bone. But with epilepsy and with mental illness, people don't understand why it occurs. So they come up with explanations like, this person must be inhabited by a demon, by a bad force, because why else would they have such abnormal behavior? Okay, so in our care of our patients with epilepsy, it is our responsibility to take some time and help them understand what's going on when they're having a seizure, to help their family members understand. And of course, you know, the people that we take care of, they don't have the level of education that we have. So we have to come up with the best way of trying to describe what's going on. And I'll leave that to you. But if we can do that, I think we help people understand that a person living with epilepsy, if they don't have any other abnormalities going on with their brain that affects their ability to think, to learn, to work, that they can live a very, very fulfilling life. They can be completely normal other than the fact that they have these occasional events. Now, of course, there are people living with epilepsy who also have significant problems with cognition because the brain disorder is doing more than just having epilepsy. And so they have a much, much more difficult life. They won't necessarily be able to progress in school. They won't be able to necessarily hold a job. But we have many patients who are unfortunately are in those situations, and we need to be able to provide the kind of social support to allow them to have the best life that they can. The other thing about someone living with epilepsy is that if they have uncontrolled seizures, they are at risk during the seizure of injuring themselves. So we need to counsel them that they need, if their seizures are still occurring, that they need to avoid situations where having a seizure might be very, very injurious to them. So for example, someone who's having uncontrolled seizures can't go back to driving until the seizures are brought under control. They shouldn't be swimming alone. They can swim as long as they have people around them who are just going to keep an eye on them. They shouldn't be climbing up into trees or up on ladders, where if they have just a brief event, they could fall and really injure themselves. So that's another part of the counseling. And then finally, for our patients who are taking anti-seizure drugs or ASDs, anti-seizure drugs, we should just be aware that these medications have various kinds of side effects and toxicities. And it's up to us to read up on that and make sure that we're aware that drugs like phenytoin can cause changes in the gums. They can cause changes in the blood. Carbamazepine and valproate can actually have effects on our blood. Valproate can have effects on the liver. So we just need to monitor for the different types of symptoms. And if we have a person who is taking these drugs, and even if their seizures are not under control, but they're complaining of, for example, just a lack of energy, we might be concerned about their hematocrit. If they have a rash, we need to be very concerned about that because could due to the drug, and we might have to adjust the dose. So when we do our visits or when they're coming in the clinic, we want to just do a general review of symptoms to to see if there's anything that might be related to the drug that they're on. So with that, I see we have about 8 minutes left, and I've covered the topics. And Diane, if it's okay, or Dan, should we just go with additional questions until we're done? Okay, let's see. What is the role of, oh, really? Yeah, what's the role of the lab in the diagnosis, treatment, and management of the condition? Yeah, Jeffrey, thank you. So very important in the initial evaluation of a person who's come in with what we think is a seizure, to do the kind of general metabolic screening that you're capable of doing out of your lab. And as I mentioned, as an example, a CBC, certainly a glucose, if you have whatever access you have to liver function and renal function tests, assessment for any underlying infection, those are the kinds of things that we would do for the diagnosis. I learned from talking to Dr. Morgan the other day that an EEG is not something that you have regular access to. And so you're going to rely on your clinical acumen. But I would like to see if someday we could have an EEG at your site, because it can be it's a very effective tool for getting to kind of the next level of diagnosis of people with epilepsy. And in terms of treatment and management, as I just mentioned, there are certain side effects from the drugs that we use. And in some cases, you may have to have some additional clinical testing to see, for example, if the person's developed liver toxicity from a drug such as valproate, more common in younger people than older. What is the role of surgery in the treatment of epilepsy? Again, a really important question. It turns out that we have patients who are not going to have their seizures brought under control by any combination of anti-seizure medicines or other holistic approaches. And these are patients who have focal seizures due to some kind of, typically an acquired abnormality, like traumatic brain injury, or a developmental abnormality that occurred early in life. But it is a region of the brain that is causing the seizures, and it's not responding to medications. In those cases, in selected cases, surgery can definitely be effective. And I'm assuming in your central metropolitan areas where you have epilepsy specialty centers, that in fact some degree of epilepsy surgery is done. So those patients need to be referred to an epilepsy center. Can a baby with recurrent history of convulsions in childhood develop epilepsy in future? Really, really good question. So it turns out that about 7 to 10% of young children will develop a seizure in the setting of fever. And as I referred to at the beginning of the hour, we call those febrile convulsions or febrile seizures. Does that mean they have epilepsy? No, not necessarily, because it could just be due to whatever the fever was causing the fever, whether it's malaria or infection of the ear, otitis media. So the thing is, in general, children with febrile seizures almost never have more than 3 to 4 at the most. They usually occur between ages 1 and 4. So if you have a child, an infant or a child, and they've come in simply with a convulsion in the setting of a fever, and it's happened once or twice or 3 times, that child probably does not have epilepsy. They'll never have another seizure. On the other hand, if they have more than 4 or 5 febrile seizures, if they have focal features of the seizure, that is, one side of the body shaking rather than generalized, or if there's a family history of epilepsy, those are situations where we're more concerned that what looks like a simple a febrile seizure might actually lead on to epilepsy. Let's see. Yeah, shouldn't be near a fire. Yeah, Diane, thank you for pointing out that a person with epilepsy needs to be really careful about being close to a fire for concern about injuring themselves. What would happen when one uses sedatives on sedatives, meaning like if you're talking about drugs like benzodiazepines, they're useful for stopping a seizure at the moment, but They can also lead to sedation. So that's, you'd have to take care of the patient as they're recovering from the sedative effects of the drug. Besides carbamazepine and Lamictal, how do you choose the anti-seizure drug? Oh my goodness. I've spent pretty much my entire career trying to figure out the answer to this question. Unfortunately, we have very, very limited indicators as to which drug works best for a given patient. It's incredibly frustrating because we don't have what we call a biomarker, some lab measurement that we could take that then says, you should use this drug for this patient. The analogy is, look what we do when we have patients with infections. If we can identify what the germ is, we can pick the right antibiotic. But we're not in that situation yet with epilepsy. But I gave you some general guidelines that certain drugs you should start with a focal or focal with secondary generalization as opposed to generalized. And then an equally profound question: how do you know when to stop the drugs? Again, I'll just repeat what I said. I've spent my entire career working on this problem. And we don't have a biomarker. We don't have a measurement that we can say to the patient, your epilepsy has gone away. And I dream for that moment. I dream for that time. The EEG can sometimes be helpful, but not generally not. And so as a general rule, what we do here in the US is if a person has been completely seizure-free for 2 years, we are ready to consider tapering off their medications very carefully. But 2 years of complete seizure freedom. And remember, a person may have convulsions, but they also may have those auras. If their convulsions have gone away, but they're still having their auras, they still have epilepsy. So we're talking about the person who developed epilepsy, went on medications, and has now been completely free of seizures of any kind for 2 years. In those situations, we will try to taper them off their medications. And in roughly 70% of the time, they won't have seizures again. But that means that about a third of the patients that we put through this will actually develop seizures again, which means they have to go back on the medication. So with that, we've come to the end of the hour and a half. You can probably tell I could spend another 5 hours with you. But I really hope that this has been helpful. I'd be more than happy to answer any questions that you have by email. Maybe Diane or Dan or Dr. Morgan, you can share my email with anyone. I love answering questions. I'd be happy to have a follow-up Zoom call at any time, to have some follow-up questions with the medical students or whatever. And I know that Milo has told me about her visit to your clinic and the work that you do there. And I really hope that someday I'll get the chance to meet you all directly. And maybe we can talk about some other neurology topics in the future.